Well, thanks for having me. I'm excited to be able to be here today and talk to you all about a subject that is very near and dear to my heart and that I always jump at a chance to talk about because I love to talk about insomnia. And my hope today is to, as the title implies, break some myths and raise some consciousness about what I would call the disorder of insomnia. I think that as a whole, we tend to think about this in a very different way that it needs to be thought about, and I'm hoping to show you that today. So without any further ado, let's get started. What's the definition? What are we really talking about here when I talk about insomnia? I know from talking to people that a lot of people have different ideas about what that looks like. Well, I know it when I see it. Here's what it looks like, right? Lying wide awake, staring at the clock, doing those sorts of things. Some of you may be familiar with this posture. To get more technical, really we're talking about a disorder of initiating and or maintaining sleep. And in truth, in most of our classification schemes, our diagnostic schemes, there is no definition for severity of how long is too long to get to sleep. After all this time, it's interesting that we haven't really put that down on paper. But I can tell you that the sleep community in general all agree that about 30 minutes is too long, that one should be able to fall asleep faster than that or reinitiate sleep if you wake up in the middle of the night. 30 minutes is a pretty long time. It's a full sitcom. So that's a long time to be laying there, right? So I have trouble getting to sleep if it takes me more than 30 minutes to fall asleep. Trouble with maintenance insomnia, that is middle of the night or end of the night, if I'm awake for 30 minutes or more, some combination. So maintenance insomnia can have a lot of different faces. We can have maintenance insomnia if we're awake for an hour in the middle of the night or awake for 2 hours in the middle of the night. Maintenance insomnia if I wake up earlier than I want to by more than 30 minutes. And maintenance insomnia if I wake up 5 times during the course of the night for 10 minutes apiece. Those look very different, but all of them would be considered maintenance insomnia. The next piece of the definition, as you see, is the difficulty occurs despite adequate opportunity, which means I have to at least give myself some chance to sleep. There are people who are not getting enough sleep in our society. They're burning the candle at both ends. Some of you may have at times or now be doing that, having lots of things to do, work, projects, whatever it is, going to bed late, then needing to get up early in the morning for one reason or another, and you're not getting enough time to get enough sleep, and you may be tired as a consequence of that, but that's not insomnia. We're saying if we give myself the opportunity, but I can't get it, and I'm laying there and I can't sleep, that's insomnia. And then the next thing we have to keep in mind is that I think of insomnia disorder as a 24-hour disorder. It's not just about the nighttime. So we don't actually fully make the diagnosis of insomnia without taking into account what's happening during the day. And in order to make the diagnosis, there have to be some sort of daytime consequences. So if I'm having trouble initiating and maintaining sleep, do I then feel one or more of these symptoms? Tired, fatigue, low energy. Problems with concentration, problems with performance of one type or another, mood disturbances like irritability. I usually have to ask the bed partner about that. Motivation and energy, proneness for errors, and also physical symptoms like tension headache, stomach ache, that sort of thing. And even just having concerns or worry about sleep. All of these would be considered symptoms of the sleep loss the night before, and we need to see some of that in order to make the full diagnosis. If one is having problems initiating and maintaining sleep, but feel absolutely perfect during the day, then that's not insomnia. Now, that doesn't mean that that person likes laying there in the middle of the night, and there may be things to do about that, but that's something different. Any ideas why somebody might be laying awake at night and not feel good during the day, feel fine during the day, rather? That's right. The truth is that we all have a different, what I would call, sleep number. You all have a sleep number. It has nothing to do with the sleep number bed. But it means the right number of hours to feel rested during the day. And there are people who need less than others. And some people who need less sleep, if they're in bed for lots of hours, they're going to have some signs that they don't sleep, but they'll feel fine the next day. So for the diagnosis of insomnia, I have to feel it. I have to feel like there's a consequence to my not sleeping. Also want to draw your attention to this idea at the top of fatigue or sleepiness. We tend to use those terms interchangeably. But the truth is, in sleep medicine, those things are not the same. Fatigue is this. This is fatigued. Tired, run down, worn out, needing stimulants to get myself through the day, bedraggled. Anybody recognize these signs and symptoms? This is tired, okay? And this is sleepy. Sleepiness is a proneness to fall asleep, to be ready to fall asleep. And the interesting thing about this is this: most people with insomnia don't get very sleepy. You don't see this as a symptom for most people. Some do, but when I do evaluations of people with insomnia, when I ask the question, do you get sleepy, and define this, most of them will say, I wish, right? I wish I could feel that sleepy. Certainly, they don't feel sleepy at the right times. Some will have some sleepiness during the day at certain times, but for the most part, they feel more what we would call tired but wired. You can be exhausted in the middle of the night and not feel like you're sleepy. And so I wanted to make that distinction for you because that's often the case. So, insomnia. I mean, really, is this that big of a deal? Insomnia? We have lots of other things to worry about in the world. Is insomnia a problem? I'm thinking it must be a problem at this point because Dr. Oz is starting to talk about insomnia. Now, I think that actually that's a good thing. The truth is, sleep medicine is a relatively young science. And so we have only just started really to explore this in the last, relative to medicine, in the last 20 to 40 years. And that's relatively recent in the history of medicine. So I think it's good that it's starting to get into the mainstream culture and that people are starting to talk about sleep because, as I will about to show you, it really is a much more significant problem than any of us give it its due. First of all, let's just talk about numbers. Just a show of hands. How many people here have ever, in your life, ever had a bad night of sleep? And everybody's laughing. And I could do that in an audience of 200 people, and it wouldn't matter because that's universal. That's not really the problem I'm talking about here. All of us have had the experience of either difficulty initiating sleep, but the problem comes when it starts to build on itself and become more chronic. So right now, the estimates are that anywhere from about 30 to 35%, that's almost a third of the country at this moment, are having some problem with at least acute bout of insomnia, which means that they're having troubles initiating and maintaining sleep more than 3 nights for up to 3 months. That's usually associated with some stressor. Something's happening, right? We're coming up on tax time, the stock market is going down, whatever the issue might be that might worry somebody, might keep you not sleeping for a little bit of time, but we expect whatever it is, whether it's illness, whether it's psychological, whether it's stress, that when that stressor emits, when it gets better, when we've dealt with it in some way, that the problem goes away, the insomnia goes away, and for many people that is the case, maybe for up to 70%. But for anywhere from 10 to 30% still, and even the 10% number is a huge number, for some that insomnia does not go away. And so when we start to talk about chronic insomnia, what we're really talking about is trouble initiating sleep or maintaining sleep for more than 3 nights a week for more than 3 months. And something happens once we cross that threshold. I think it's even less. I think it's more like a month. Because once we get beyond that period of time, it doesn't tend to go away by itself. Regardless of whether the stressor emits or not, for some people, for up to 10%, which is a huge number when we're talking about this, it does not go away without there being some intervention. And by the way, and I'm going to show you this, we don't tend to talk about it. So do I see people who have had insomnia for 4 months? I wish, but I don't get them that quickly. Most of the patients I see have had their insomnia for 5 years, 10 years, 20 years, 30 years, and 40 years. Once you cross that threshold, it doesn't tend to go away. And what does it do? It affects everything. Now, if we had all day, and believe me, I've talked about insomnia all day, I could show you slide after slide after slide that essentially shows you what I'm summarizing here, which is essentially this. Anything you want to measure, the worse the insomnia gets, the worse the problem gets. So insomnia has impact on everything, from quality of daily function to my quality of life, to personal safety, to increase in accidents, to absenteeism at work, or what we might call presenteeism, which means I show up to work, but I'm not functioning at the level that I should be functioning at. I'm not as efficient. I'm not doing things as well. So it affects all aspects of our life. More so than that, insomnia is associated with increased medical morbidity, which means increased medical problems. Insomnia is now associated with diabetes, heart disease, and cardiovascular disease, and weight gain. So, it used to be thought, and again, we're going to talk more about this, but it used to be thought that the insomnia was more perhaps a byproduct of those things, but the data is becoming more and more clear now that we're studying this, that it's actually a risk factor for those things. It's also associated with increased psychiatric morbidity. That is, an increased likelihood of developing problems like depression, especially depression, and I will show you some of that. But definitely associated with anxiety disorders, associated with other kinds of psychiatric disorders. Insomnia is really one of the characteristics and symptoms on just about the list of any psychiatric disorder you could look at. And again, it's becoming more and more clear that the arrow is a two-way street. So it's not just that it is a result of these things, but may also be a risk for and a cause of some of these problems. So in summary, is insomnia a problem? I'd say it is. We're talking about an extremely prevalent disorder with high personal and social cost that's associated with increased medical problems and increased psychiatric problems. If this were any other label but insomnia, we would be alarmed. And the numbers in terms of prevalence would be epidemic. And we'd be talking about it all over the place. But we don't. Given that this is such a substantial problem, how is it being addressed? What do we do? And the answer is most of us suffer in silence and try to fix it on our own. So what do? We take over-the-counter medications. We drink alcohol. There's a really particularly poor idea for how to deal with your insomnia. Some people are going to the doctor and getting prescription medications, but that's still a very small percentage. And when we sum up everything that everybody's doing, notice that that's only 25%. So that means somewhere around 70% of us are absolutely doing nothing, despite the fact that we're suffering from chronic insomnia, and despite the fact that it does all of those things that I just showed you. We all just suffer in silence. And what percent of us actually go to the doctor and talk to our physicians about our insomnia? Again, a very, very tiny percentage, roughly around the same point. 6% on this slide, which is a Gallup poll that was done in 1995. Now, that's a while ago, and I suspect that that number has gone up somewhat, but still not greatly. Why do I think that number has gone up somewhat? Since 1995, we have this wonderful thing we now have added to our culture called direct-to-market advertising. So now you all have seen the advertisements for Ambien and Lunesta and all the happy, smiling, sleeping people. And at the end it says, tell your doctor about Ambien. I once heard a comedian say, tell my doctor? If I tell my doctor what to take, doesn't that make him my pusher? So, yes, I think probably the numbers have gone up some, but still, I think the number of somewhere probably around 60% of us are suffering in silence, not mentioning it to the doctor whatsoever. We have this incredibly prevalent, incredibly destructive, very difficult disorder, and none of us are talking about it. Why? And this brings me to my idea of trying to raise consciousness and think about how we think about insomnia. Sometimes I title this talk, It's Not Your Father's Insomnia Anymore, or Your Grandparents' Insomnia Anymore. The way we have thought about insomnia, I'm going to try to break some of that way of thinking and show you what the research shows us up to date. But I'm here to tell you that, clinical practice often, we know this in research, clinical practice often lags behind the research by 10 to 15 years. And what we know in research, clinical medicine hasn't picked up on yet. So even medicine still continues to think about insomnia the old way. Why is it? What are some of the myths that we hold about insomnia that cause us perhaps not to talk about this a lot? And I think the first is, and medicine used to say this, I remember when I was first starting in this business, the American Academy of Sleep Medicine had a slide deck that it could provide all its practitioners to say, if you want to give a talk, here's some slides on insomnia. And the first slide in the deck was, insomnia is a symptom. And the implication of that is, therefore, just treat the main disorder that caused the symptom and the insomnia will go away. But I just showed you that 10% of individuals where the initial precipitant goes away, the insomnia doesn't go away. So that turns out not to be the case. Here's the classic view, certainly in psychiatry, and I'll talk about depression a lot. The classic view was, if I'm depressed, one of the symptoms of my depression is insomnia. Okay. But that turns out not to be the case in the data. And if you start to look at people who have insomnia and just follow them over time, when we start to do what we call longitudinal studies, we can show that having 2 weeks or more of insomnia starts to raise the probability that somebody will have a first episode of depression. And what comes first? The insomnia. This is why I'm saying this is a risk factor, okay? And not just a symptom. So we now know that insomnia confers at least a 2 to 4-fold risk. 2 to 4 times as likely to develop depression with chronic insomnia than I am if I'm not. And if I have depression and comorbid insomnia, that is, I have insomnia along with it, it makes the depression more resistant to treatment. And we now have data that shows that if I treat the insomnia in the context of depression, I can double the remission rates for depression. Okay? It's important, therefore, to be talking about this. And as I said, poor sleep is already, and we know, associated with hypertension, obesity, metabolic syndrome, and so forth. So, is insomnia just a symptom? I hope we killed that one. What next? So this is the classic psychiatric view. This is what we now know. If I have bad sleep, then that is going to make me more predisposed to things like depression, probably more predisposed to things like anxiety. How about this one? And this gets into my whole aging thing. So here's another myth. Babies sleep great, right? But as we age, and I just heard this week, one of the people who came in for our study just said, well, I didn't think there was anything you could do about this because it's just the way it goes when you get older. Well, there it is. There's one of my myths. Babies sleep great, and as we age, it's just the way it is. You just get insomnia. Why should I bother talking to my doctor about it? Well, let's take a look at that for a moment. Sleeping like a baby. Is that really a good thing? Let's look at the profile. Babies go to bed excessively early, right? Their sleep is very fragmented. Look at the sleep of babies. They sleep and they're awake and they sleep and they're awake and they're asleep and they're awake. Some of you are probably saying, yeah, just like me. Exhibit pathological levels of daytime sleepiness, like my colleague over here. The urge to nap during the day is completely irresistible, like my colleague over here. And babies wake up every few hours for food. Is this the way we want to be sleeping? I would say not. Don't give me sleep like a baby. I'll take sleep like an adolescent. Now those people can sleep, okay? But not sleep like a baby. That's not how I want to be sleeping. Okay, how about the other side of this equation? It's widely assumed that the elderly sleep poorly. Let's look at that for a moment. It is absolutely, in some myths, in some things that we believe, there's always a kernel of truth. There's certainly the truth that there are a lot of things that happen as we age that assault our sleep. So, again, like I said, just about anything we could measure gets worse if I have more insomnia. Unfortunately, we could make the same claim about aging. Just about everything we could measure, I'm afraid, gets worse as we get older, except wisdom. That gets better. Depression is more prevalent when we get older. Disorders like reflux and thyroid dysfunction and prostate enlargement, which makes us have to use the bathroom more in the middle of the night. Sleep apnea becomes more prevalent as we get older. And of course, with aging becomes all kinds of little aches and pains and maybe chronic pain. And for all of those things, there are medications. And all the medications have side effects, right? Direct-to-market advertising, let's go back to that. All of these, no matter what they're treating, as I said, they have smiling, happy people dancing up and down the streets, and there's a nice soft voice overlaying the ad telling you about all the wonderful things the medication is going to do for you. And at the end, the very fast voice comes on and tells you all the terrible things the medication is going to do to you. And one of those things is sleep and sleep problems. So yes, there are lots of assaults on our sleep as we get older, but I'm here to tell you that, and we will show you, that there are ways to fix some of that. Some of the things that I also want to show, and if I had a longer time to speak, I'd define some of these things better, but I want to talk about the fact that yes, as we get older, our sleep architecture changes. What do I mean by that? Sleep architecture refers to, and many of you probably heard, when you sleep, if we bring you into the lab and we wire you up and we measure you for brain waves, our brain waves define what stage of sleep we're in. Whether we're in a light stage of sleep, a deeper stage of sleep. These stages are aptly named stage 1, stage 2, stage 3, and stage 4. Stage 3 and 4 are deep sleep. Those are our deepest levels of sleep. Some people think REM sleep is the deepest level, but it is not. It's actually a very agitated, wakeful type of sleep. They're all important stages, even though people tend to think there's some more important than others. And what this is showing you is that the deep sleep tends to get less as we get older. We do get a little less sleep. We get more of that going into stage 2 sleep. REM sleep, as you see, sort of goes up and down over the course of the lifespan. But none of that, first of all, there are no correlates for this. I showed you what happens when there's sleep disruption to mental health, to physical health. There are no correlates to what happens if we get less deep sleep. There's nothing that says getting less deep sleep will lead to this problem, this problem, and this problem. There's none of that. And none of this says, therefore, I should be awake in the middle of the night for 2 hours. Therefore, when I get into bed, I should not be able to fall asleep. That's not the same thing. So if you've heard that sleep changes as we get older, that's true. But insomnia doesn't have to be there. Sleep doesn't have to be lousy. The other thing that happens is that there's a change in phase. So I've already talked to you about the fact that we all have a sleep number. And that varies from you to you to you to you. And we also all have a preferred sleep phase. You've all heard or thought about the idea and maybe characterize yourself as more lark-like or owl-like, morning people or evening people. That's what we mean when we're referring to phase. What it means is we all have the right number of hours, and we all have a time of day in the 24-hour block when we're most likely to get that sleep and get it well. Okay? So some people are going to get 7 hours if that's their number better from 10 to 5, and some people are going to get 7 hours better from 12 to 7. That's what we mean by phase. And phase does change over the course of the lifespan. So this is just showing you that. There's our newborn at the top, by the way. Sleep awake, sleep awake, sleep awake, sleep awake, sleep awake. Don't want to sleep like that. And then at 1 year of age already, we're consolidating that sleep pattern with a few naps during the day. Get a little older, we lose a little bit of the naps. By the time we roll around to about 8, 9, 10 years of age, to the utter consternation of our parents, all the naps have now disappeared, and we're awake all day long. And the sleep of a 10-year-old is long and early, right? If you look at the time frame at the bottom, that 10-year-old is sleeping about 9 hours, goes to bed early, wakes up early. When my son was about 4 years old and in his big boy bed, he could get out by himself and he would come into our bedroom and he would do this to my eyelid to see whether I was awake. And I was at that point. And then he turned into a teenager. And that's what you're seeing here. What you're seeing is what we call a delay of sleep phase. So teenagers delay. And that is why all of a sudden they're going to bed much, much, much later. And it takes dynamite to wake them up before 12 o'clock. Right? That's a biological shift. It's not just that they're more active and they've got more things to do or they're partying. I mean, they're doing all of those things, but biologically, they're more prone to go to bed late and get up late, and it's difficult for them to sleep outside of that phase. And what you're seeing is the rest of our lives we spend, what we say, advancing back the other way. So if you look at college dorms, most of the people in the dorm are going to bed between midnight and 2 a.m. And if they have late classes, waking up anywhere between, let's say, 8 a.m. and noon, if they're lucky. And if you look at a retirement community, most people are having dinner at 4 o'clock, going to bed at 8, and waking up at 4. Okay? So yes, there's a change in phase that happens when we get older, but again, nothing there says, therefore, I should wake up in the middle of the night and not be able to get back to sleep for 2 hours. None of this says that our sleep should be lousy. None of that is absolutely a part of getting older. So, is it true that babies sleep great? No. And is it true that we have to live with poor sleep as we get older? And the answer there as well is no. So again, this may be a reason why you don't speak to your doctor, but I would say it might be a good one to do. Insomnia cannot be treated without using a pill. This, I think, is also a very common reason why we don't want to go to the doctor to talk to them about our insomnia, because we figure the only answer they have for us is another medication. And we don't want to be on another pill with more side effects, and we've probably heard that some of these pills may be habit-forming, and we just don't want to go there. And the truth is, as I said, medicine is taking time to catch up to this. The average physician gets about a half hour of training in sleep medicine in 4 years of medical school. So you're all getting more than they have. Okay? So they too really don't want to hear about it much. I have other slides that show that most doctors don't ask you about your sleep either. My doctor asks me about my seatbelt usage before she asks me about sleep. Okay? So yes, we don't want to go down that road of necessarily having to have a pill. So is that true? Is that the only treatment? So let's talk a little bit about the treatments for insomnia. I'm going to talk mostly about pharmacotherapy and something we call cognitive behavioral therapy for insomnia, CBT-I. This is what I do. This is what I've been doing for 30 years, and that's a completely non-pharmacological, non-medication treatment for insomnia. I'm happy to answer questions afterward, and I'll talk offline, but we can talk about herbal preparations and over-the-counter things later. This is basically just showing you that the NIH holds these State of the Science conferences. And what they do is they will look at a specific disorder. And in looking at it, they will look at all the research over since the last time they did the State of the Science, whatever it is, a 10 or 15-year period, and they'll look at all of the available research on treatment and make some conclusions about what they can actually recommend and say is a data-based treatment for the disorder. The last time they did this on insomnia or insomnia disorder was 2005, and what they concluded then, and it really hasn't changed much since then, is that there are two things that they can recommend for the treatment of insomnia. And one of those things is benzodiazepine receptor agonists, and what that is your newer class of sleep medications. Ambien, Lunesta, Sonata, those medications. And the other is cognitive behavioral therapy for insomnia. And they endorse them both equally and say there are good guidelines and good research, which we know about, to support both of these. Now, before this happens, and I know it happened at least once, so I always give this disclaimer, on the other side of the equation, there are things like antihistamines, antidepressants, antipsychotics. Often these things are being used to help manage insomnia. This is not saying that those things don't work. They're not saying they're bad and don't take them. And please do not go home and say, I'm stopping all of my medications because Dr. Posner told me so, because I did not. Never change any of your medications unless you speak to your physician. All this is saying is there's no data, right? Number one medication prescribed in this country for insomnia, the number one medication, trazodone. Trazodone is an old, dirt-cheap antidepressant. And at low doses, meaning doses much lower than you would ever give for depression, it still has the side effect of being sedating. And so it's prescribed what we call off-label. It was never studied for insomnia per se. It was only studied for depression, but we know it's sedating, so let's try it. That's called off-label prescribing. And take it from me, I can tell you that it works. It'll knock people out. But how many studies on trazodone and insomnia in large controlled studies? 1. There's not enough data for NIH to make those conclusions. But what we do know is that these other two forms of treatment work. And how do they compare? How does pharmacotherapy, that is, pharmacotherapy of any kind, but especially with those newer class of sleep meds, compare to cognitive behavioral therapy? Is this an accurate portrayal? This is the way we tend to think about things a little bit, some of us, right? Medications, that's the real stuff. even though we might not want to go there. And then there's this therapy stuff. I'll talk to somebody, maybe they can help me, but it's kind of weak tea, right? Except in this particular case, that turns out not to be true. Okay? So here's a number of different studies that begin to tell us about comparisons of cognitive behavioral therapy to pharmacotherapy. And the first big, and I'm going to show you two of these studies, both in terms of outcome data, but also long-term data. And I'm going to look at Wu and Morin. And the first one is this study by Morin. And what this is measuring here is wake after sleep onset. That's one of the measures we wake. That's maintenance insomnia. That's saying somebody's waking up in the middle of the night and they're awake too long. Can we reduce that? What we want to see is the lines go down. And what this is basically showing you, PCT is pharmacotherapy. That's the medication. The blue line is CBT-I. What it's showing you from pre-treatment to post-treatment is that they're equivalent. That they're essentially going down about the same amount, that they do the same job. And if you look at study to study to study, this is what you're going to find. You're going to find that CBT is absolutely equivalent, that it does just as good a job as medication in getting people to sleep. But here's the beauty. Look at what happens. Think about what happens. I take a medication, it works. What happens when I stop taking the medication? That's what post-treatment means. After post-treatment, I stop the medication or I stop the therapy. Well, after you've stopped therapy, you've learned what you've learned. You can't unlearn it. And so when you stop the medication, the effects start to dissipate. And if we look at 2 years down the line, that data is almost back to baseline. That person's sleeping just about as poorly. But cognitive behavioral therapy has maintained a lot of those gains. And that's what we see in study to study to study. Here's another, so here's the really good news on total sleep time as well. In the beginning, pharmacotherapy does a little bit better at boosting the amount of hours you get. So at post-treatment, people who are on medication might be getting a little bit more sleep. But then stop the medication and those gains go away. But cognitive behavioral therapy, once you learn how to sleep well, part of our data shows us that when you look down the line, people start sleeping better and better and better at 1 year follow-up, at 6 month follow-up, at 2 year follow-up. That's great data. Here's the Wu study. This is looking at initiation insomnia. Again, both have very good effects on getting people to get to sleep, but the effects dissipate over time. This was only an 8 month follow-up, but you stop taking the medication, the effects go away. You stop CBT-I, you've learned what you've learned, and the effects maintain. And we get that same crossover. Total sleep time improves over time once you've stopped the work. Okay? So that's what we now know, and what we can say is cognitive behavioral therapy is absolutely equal to medication in the short run, and CBT has the edge when it comes to long-term treatment of insomnia disorder. So insomnia cannot be treated without using a pill? Okay. So some of you may be asking, what is CBT-I? Well, I'm going to start by telling you what it isn't, because sometimes when we talk about non-pharmacological treatments, people confuse it with something we call sleep hygiene. Everybody and their uncle has advice when you have insomnia, right? You may not talk to your physician, but you might tell your friends or your family, hey, I haven't been sleeping well, and everybody's got advice. Drink tea, read some more, take a warm bath, cool your feet down, cool the bedroom, put on an eye shade, whatever it is. Everybody's got advice. And this is what winds up happening. You wind up being this obsessed, crazy individual about, I mean, I have people who have insomnia who have lucky pajamas, right? Lucky toothbrush, right? They have to spin around 3 times before they jump into bed. It's a mess. And what I can tell you about sleep hygiene is, sleep hygiene, all these things you hear about, change your caffeine consumption, change alcohol consumption, change your exercise, they matter, they do matter. But by the time you get into that chronic insomnia I was talking about, the data is clear. Sleep hygiene alone is never enough. So if some of you have said, oh, I've heard some things to do and change behaviorally without medication and that never worked, I'm with you. It doesn't. But that's not the full story in CBT-I. That's just the tip of the iceberg. That's something I would address if I was treating somebody, but it is by no means the major factor. So again, is that CBT-I? No. It's a piece of the puzzle, but it's not the whole story. Again, we'll come back. What is CBT-I? The truth is, when we start looking at something called chronic insomnia, there's a lot of different aspects of what goes into good sleep that can start to go awry. The biggest problem is that when people have trouble sleeping, they start to respond to the fact that they're sleeping, right? If you have a problem like you're concerned about the stock market and that caused you not to sleep for a while, and then the stock market rebounds and you feel better, but somewhere in there you start saying, my God, I'm not sleeping. You can see where that starts to become an issue, a stressor, a problem. How am I going to sleep tonight? How do you think that affects your sleep when you're getting into bed, right? So there are lots of different things. I don't mean to suggest just that. Lots of things that can go wrong with how we begin to approach our own sleep. And what it starts to do is screw up the things that normally regulate sleep. So we all have a sense of something called a circadian rhythm. We all have an internal clock. And when we have insomnia, week after week, year after year, that clock gets misset. And then it takes some doing to reset it. And not everybody knows exactly how to do that. And so you need to reset that clock. And if you don't, you're going to continue to have insomnia. We also have something called a sleep drive, a propensity, a push to need to sleep, very much like hunger. The more I go without food, the more hungry I get. The more I go without sleep, the more my sleep drive builds. But that too, in terms of the things that people do for their sleep, can get weakened. And when sleep drive gets weakened, I'm not going to sleep as well, no matter how well other things in my life are going. Conditioned arousal, as I said, after a while, we can all start to think that, you know, the whole aspect of going to bed is stressful. So that can make us sleep worse. Many of my patients will come and say, I think the reason I don't sleep is because my mind is racing. And that too becomes an issue. Is sleep hygiene part of it? Yes. As I said, one piece of the puzzle. And then, of course, there's just still all the old worries about everything else that might be going on that sometimes happen at night. And the truth is, for each person that has chronic insomnia, it may be a different combination of these factors. Not everybody's insomnia is the same. Not everybody's looks exactly the same. Everybody's looks a little bit different. So I know that what you would like me to do next is do the same equivalent of what they do with sleep hygiene. Okay, here's 10 tips for a good night's sleep. Don't drink so much coffee. Don't drink so much alcohol. Get more exercise. That you've heard enough. You don't need to hear it from me. And I just told you it doesn't work. And I'd love to say that I can give you a similar list of, okay, so how do we fix all of this? But it feeds into the same old problem we always used to think about insomnia. It feeds into this idea that insomnia is trivial. If I were up here today talking about diabetes, would I give you 10 tips for fixing your diabetes without going to your doctor, without getting it properly assessed, without getting a blood draw? No. If I start doing that, I'm starting to give you advice without a plan. I said each one of you has insomnia for different reasons. And until I do a thorough assessment, my giving you out advice is like a radio psychologist giving advice to somebody they don't really have any idea what their life is like and what the factors are in their life. It would be like going to the doctor and saying, sure, I'll set that broken leg. We don't have to bother with an x-ray. Not a great idea. So that's not my goal today. My goal is to raise everybody's awareness and have you understand about this and to know that there is help. Yeah, medications do help, but you don't have to go down that road. When I say this stuff, does this stuff work? I mean CBT-I. Absolutely it works. I showed you that really already, but there's now overwhelming preponderance of evidence that cognitive behavioral therapy for insomnia works. We've done study after study in young and old, and time after time we've shown that it works. And the truth is we don't need to do those studies anymore. My colleagues and I are working on a study at the VA, Palo Alto VA, and what we're doing is we're breaking it down now. We're saying, look, there are cognitive pieces to the treatment, there are behavioral pieces to the treatment, and which of these work best? And which of these work best and for whom? Because some people may need the behavioral more than others, some people may need the cognitive more than others, and how do we assess that? So we're offering a treatment study where we're looking at how do people do on the cognitive alone, how do people do in the behavioral alone, how do people do in the combined version together. And the nice thing about our study, and I'm only going to say this for a little bit, the nice thing about it is that there's no placebo condition. You come into our study, you're going to get treatment. You're going to get real treatment for insomnia, and everybody that comes in is getting at least some version of the treatment. There's no placebo condition. There's no treatment aspect to this. What we're looking for is people that are 60 and older. They do not have to be service connected. So even though we're running the study at the VA, we'll take people from the community. And you have to be 60 and older. And so that's our study. And I will answer questions about that later. And Dr. Friedman, who is the PI on the study, is here as well. And so we'll all be willing to answer questions about it later. If anybody's interested, you're welcome to sign up. And that doesn't sign you up for the study in blood. All it does is it means we'll give you a call and we'll answer your questions about it and we'll see whether you fit into the study profile and so forth. We also have flyers if people want to take that and not have their name put down. And the other nice thing about getting treatment for your insomnia is, in our study, you don't have to pay us, we'll pay you. So that's another nice factor. Let's go back to myths. Here's another reason why I think still I might not have sold everybody. I will bet that there's at least a few people in the audience who are thinking, yeah, this is all very nice, but I know why I don't sleep. I don't sleep. And some of it may be the things we talked about. I don't sleep because my mind races. Some people might be saying, yeah, I know why I don't sleep. I don't sleep because I have chronic pain. Oh, I know why I don't sleep. I don't sleep because I'm a nervous wreck, and I know that. And so, that used to be the thinking. The thinking used to be, well, insomnia is just a symptom, and if it's just what I call squeaky clean, if it's just there by itself, sure, all this CBT-I is nice for those people who have no problems whatsoever. They have no depression, no anxiety, no pain, no cancer, no nothing. Okay? Squeaky cleans. I worked in Rhode Island for 30 years treating insomnia in the state of Rhode Island when I was working at Brown University. I've seen those 6 people. They're done. What I'm showing you now is just a modest list of all the studies that have been done to show, and SI here stands for secondary insomnia, to show that when you treat insomnia with CBT-I in the context of cancer survivorship, it still gets better. When you treat it in the context of various psychiatric disorders, especially depression, post-traumatic stress disorder, and other anxiety disorders, it still gets better. When you treat it in the context of pain, it still gets better. Okay? So this idea that if I have those things, I can't make my insomnia better is just not so. And the data for that is also overwhelming. So, the indications for CBT-I are that it works in both primary and comorbid insomnia, meaning insomnia in the context of all those other disorders, real people. Okay? It works both in younger and older adults. We can expect that 70 to 80% of the people who involve themselves in CBT-I are going to get improvement of at least 50% to 60% of their sleep onset latency or problems waking up in the middle of the night. And 40%, a full 40% will become normal sleepers and sleep perfectly well, even sometimes with all those other disorders. And one of the things that I showed you is that the sleep changes are well sustained over time. So insomnia cannot be treated without treating the primary disorder. Not only is that not true, but in some disorders we're starting to see that I can make the insomnia better, and guess what? If I treat insomnia in the context of depression, and I told you this already, but it's worth saying again, I can double the remission rates in depression. So not only is it not true that the insomnia can't be treated because I have depression, but if I treat the insomnia, I can make your depression better. I can make it more treatable. I can double remission rates. Is that true for every other disorder? No, but certainly it improves quality of life. We see this in pain. When you treat insomnia in the context of pain and chronic pain, what we see is some people say, that pain, I'd love to say your pain gets better. Pain doesn't get better. In a couple of cases, people will say, pain feels a little bit worse. Why? I've started living again. I get more active. What improves when you treat insomnia in pain conditions is quality of life, activity level, things that they're doing. People will say, I pick up my grandkids again. because I feel like I have more wherewithal, more resources to deal with the problem once I start sleeping better. So getting on top of insomnia is important. And whether you come to our study or not, please find ways to get help if you have insomnia. So my take-home messages today, and then I'm going to open it up to questions. First of all, insomnia is absolutely positively not a normal part of aging. Insomnia is not just a symptom of other things, and therefore just treat those things and we don't need to pay attention to insomnia. Insomnia is a disorder in and of its own and is desirous of its own treatment. And insomnia can be treated both with medications but also without medications. And CBT-I can work even though you have these other comorbid conditions. And treating the insomnia can have beneficial impact on the insomnia, but also on the mental and physical well-being of the individual for all the other things that they may be experiencing. So now I'm going to open it up to questions. And I'm also putting up this slide, which first of all tells me something that I always like to remember, which is things are not always what they appear, which is why we like to do assessment before I give you advice. And the name of two of our research assistants is on there, their email addresses, phone numbers. But again, if we come over to the side at the end, we have flyers with all that information on it. You can call us, we can take your name and call you, and so forth. Thank you very much. Yes?
Yeah. Can you give us the flavor or example of particular examples of CBT-I?
Yeah, so the question is, can I give a flavor or an example of CBT-I? Yes and no. I'm loath to give piecemeal descriptions. It's like giving out that sleep hygiene stuff. And the problem is, CBT-I takes about 6 weeks of an hour a session per week. Okay? So the one thing I can say about it relative to medication is, it doesn't work as fast as medication. It works in about 2 to 4 weeks and 6 weeks to taper everything off. Okay? Hold on. I'll try to get back to your question. 2 to 6 weeks of an hour per session. That's the way to make it right. When you write this stuff down, if I say to you, okay, well, you know, one thing that would be, you could do this. I know from experience that it's then going to go wrong, that it's not going to go well, and then you're going to become less likely to say that that works or I'm going to try that. So I'm going to be difficult here for you. I'm not going to tell you some things that you can do. What I will say is, I tried to talk about it before, what it does is it starts to look at those pieces. Are there ways to reset your internal clock? Yes, there are ways to talk about resetting that internal clock and making it so that it is set to the times where you want it to be set, so that you're falling asleep on time and waking up on time. But the rationale behind that, how that happens, what the time frames are for how long you have to do certain things, that's the biggest piece of this is most of the recommendations don't work overnight. So more often than not, when they're not working right away, people give up too early. And it takes a lot of education. What I like to do when I bring somebody into my therapy is make them an expert in their own disorder. And I can't make you an expert in your own disorder. I can only give you piecemeal advice at this stage of the game. So that's about as far as I'm going to go. Other questions? Yes?
Yes, would you like to, could you please talk about chronotherapy? I understand it's a new science that we're doing now. Whereas, you know, as we grow older, of course, the number of medication increase.
Yep.
And in chronotherapy, you try to time when those medications should be taken to optimize the effectiveness as well as use the side effects to the benefits, such as some medication have side effects of sleepiness. So you give those, you tell the patient to give that, to take that at night versus, you know, some blood pressure medication now are found to be more effective at night. Yeah. Since, you know, we don't have the drop in the elderly at night with the blood pressure, of course.
So the question, let me try to summarize the question so that people at home can follow along. You're asking about, can I say something about chronotherapy? And it's interesting because chronotherapy is a term that gets thrown around that often summarizes a lot of different types of things. In the particular case you're talking about the timing of various medications throughout the course of the day and how chronotherapy might work with that. I'm not sure exactly what you're referring to in that vein. The only thing I can think about are medications like melatonin. Melatonin is a medication that would be involved in something we might call chronotherapy. So I'll take the moment to answer that question because that's the question that usually gets asked, which is, what about melatonin? And I don't know whether people are using melatonin or not, and remember, anything can work for any one individual, but when we talk about a whole, I will say this, and it's relative to your question. Let me say this term and then I'll define it. Melatonin is a good chronobiotic. It is not a very good hypnotic. So what's a hypnotic? A hypnotic would be a sleeping pill. Let me say that. Melatonin is not a very good sleeping pill, taken at bedtime to get me to sleep. Because that's not what melatonin does. Melatonin is more of a substance that tells your brain something about how light and dark it is. And it's basically giving your brain a message. It's dark. Do what you do when it's dark. That's what melatonin does. And by the way, it does that for my friends over here, the raccoons. Those are nocturnal animals. The melatonin in your brain goes up at night. The melatonin in their brain goes up at night. They're not sleeping. So what melatonin does is it tells you something about time of day. And to your point of chronotherapy, there are other disorders called circadian rhythm disorders. Some people's internal clock really is stuck or really set to a very far extreme, very delayed or very early. And in those cases, trying to move that clock is sometimes called chronotherapy. Using melatonin at other hours of the day is a good way of doing what you might refer to as chronotherapy for those disorders. But that is not the problem in most insomnias. Therefore, it's not a good hypnotic and not the best treatment for that. I hope I answered that well enough. Yes?
What if the depression predates the insomnia? And some of the antidepressants do cause sleep problems.
Yeah.
What might you advise in general for
So-
people
so-
how to manage that?
So the question was, what if the depression predates the insomnia? And what if a person's on some antidepressants which can often cause some problems with sleep? So great question. Again, I certainly don't want to make it sound as if there's only a one-way arrow. It can be a two-way arrow. There's no question that insomnia is a symptom as well of depression. But it can also be a precursor. It can also be a prodrome. It can be a risk factor. So can we see signs of depression first? Yes. If you really phase back, you'll find for a lot of those folks that they did have some problems with sleeping, and it starts as a lead-in. But either way, after a while, it doesn't matter which came first, the chicken or the egg. The truth is that programs to treat sleep, and again, I'm going to talk about CBT-I, still work. It doesn't matter that the depression came first. Treating the insomnia once it's there can help treat the depression. And in the context of being on antidepressant medications that might have an impact on your sleep, CBT-I can still help to make the sleep better. Okay? Yes? Yes.
I'm curious if you work in conjunction with any physical ailment, conditions such as thyroid issues. And particularly for women as they get older, thyroid and cortisol levels can be off, and that could be a reason for no sleep in and of itself.
Yep.
And then my second question, which you won't like at all, because it's a piecemeal thing, is similar to the melatonin question, but with essential oils like lavender or vetiver.
Okay. So let me see if I can summarize this for our audience playing at home. Basically, you're asking questions about... Trigger me again. I got the lavender oil.
Thyroid.
Oh, what about in medical conditions like thyroid? There are all kinds of... People present to me all the time with a list of medical disorders. Now, remember, I said there are lots of things that precipitate insomnia. Can you start... Let's talk about some of the common things that start insomnia. Pregnancy, childbirth, child rearing. Remember those babies? They wake up for food every 2 hours. That has a tendency to put a crimp in your sleep. I have lots of patients who come to me and say, my insomnia started when I first had my child, my son. How old's your son now? He's 35. Right? So he's not bothering that sleep anymore. That was a precipitant. Can thyroid disorder be a precipitant? Yes. Can I say that if your thyroid is ragingly out of whack and your thyroid levels are all over the place, that you're going to sleep well? No. We want to make sure that certain conditions are at least treated. Some things can be treated completely, and some things can be treated only partially, right? I can treat thyroid disorder, and for most people, hope that we get it under control. But for others, like depression, for some people, antidepressants will take care of the depression. For some, it won't completely take care of the depression. In either way, I'm going to want medical disorders to be as stable as possible, but whatever is left over, can you still treat the insomnia in the context of those things? And the answer is yes. But one of the things we assess is that. Is there still problems with thyroid? Are there still problems with other sleep disorders? Are there still problems with menopause, with hot flashes, with those sorts of things? All of that is taken into account. You treat those things as much as you can, but especially with something like menopause, there's only so far you can go, right? If you're not on hormone replacement therapy, some symptoms may remain. Can you treat insomnia anyway? The answer is yes. To your second question about lavender oils, aromatherapy, everything else, I will put all those things on the list of hasn't been studied, I can't answer the question for you. Yes?
The slide that you showed about the change of sleep phases with age,
Yes.
it looked like the bar for older adults looked shorter. Does the number of hours that you need to sleep decrease with age?
Yeah, the question was, do the number of hours that you need decrease with age? That's sort of a debated question still at this point. I've heard both sides from the research community. As we age, the number of hours we need changes, and it doesn't change. At least at one point, it was definitively said, yes, we need less sleep as we get older. And then people started to really look at what's happening in the 24-hour day, and everybody started to recognize that, yeah, people are sleeping a little less at night, but they're also napping more during the day, and when you start to add up all the sleep they're getting in a 24-hour period of time, they're getting about the same amount of sleep they were getting when they were 30. So then people started saying, well, maybe they need as much sleep, they're just distributing it differently around the clock. And I really go back and forth. I can't give you a definitive answer than that, except to say this: it doesn't matter. It's like the deep sleep and or the change in sleep phase. It, I think, is true for at least some people that maybe if you needed 7.5 hours when you were 30, maybe when you're 60, you don't quite need 7.5 hours. But it still doesn't mean that your sleep should be crappy. It still should be solid. I should still be able to get into bed, fall asleep, in my book, within 15 minutes. Yeah, I probably wake up during the course of the night, but I should be able to get back to sleep within 15 minutes. And it doesn't matter whether I need 6 hours, 8 hours, or 4 hours. Did that answer the question? Other hands? Yes.
How do you feel about napping?
I love a good nap on a Sunday afternoon. No, I mean, look, napping is, again, all of these things have impact. And some people can get away with things more than others. You know, you're going to hear all kinds of advice out in the community about what you should and shouldn't do. I said, you know, everybody and their uncle has advice. And people are told, you should read in bed. You should not read in bed. We can look at all of these different things, and I think for some people it's a problem, and for others it isn't. That, again, that's why I talk about doing a good, thorough assessment. I have a partner who I do talks with, and he says he reads in bed every night. And it helps to put him to sleep. And he's been reading the same book for 30 years. So who's to argue? That's the story. So I do think that napping is something we look at. It also depends on how one wants to distribute. I think we can take control of our sleep. I want to empower people to take control of their sleep. You want to nap? You work on that. You want to not nap? You work on that. One thing I would say is hard to do is go back and forth. Because each thing you do, you're training your body where to get sleep. Other questions?
I have a question. How does sound and light affect our sleep?
How does sound and light?
Yeah, this has increased so much. And
Right.
I've always thought, oh, you are just sensitive to noise.
Well, sound and light are some of those things that they usually put into sleep hygiene. But sound is definitely, I mean, you look, I mean, what do you think? Okay? If you're sleeping, okay, and I start, you know, making noise next to you, what do you think is going to happen to your sleep? We always say in sleep hygiene, the best thing for a good night's sleep is a bedroom that is quiet, dark, and cool. Okay?
question about the data. You mentioned, you showed the slide of how our sleep patterns change. What about how do people that are over 80, I'm talking about the real end of CBT, respond to the CBT thing as opposed to younger people that are 40, 50, and 60?
Right.
Is it slower, or is it the same, or does it take longer?
So the question was, how do people over 80 respond to this kind of CBT-I? The studies that are generally done, so there's lots of studies in the elderly, lots. And we're doing one. And I've now worked with a number of people over 80, and I can tell you that we're getting good results. But the studies that predated us, that looked at the whole package of CBT-I, they don't tend to break that out. There's no study that says, here's a CBT-I study for those 80 and older, and here's a study from 60 to 80. Most of the studies include everybody from 60 on up or 65 on up, or however they want to define elderly. That's always getting younger and younger as I get older and older. So, but in my book, there's no reason to think that it shouldn't work for people over 80. We know, at least in some of those studies, there were plenty of people who are over 80 and it works. There's no data to indicate, but nobody's looked at that specifically, that it takes longer for it to work in somebody who's over 80 than somebody who's younger than that. I'm at my 1 hour time. I can keep answering questions. Or one more question. Yes?
I was just going to ask if you had a percentage, I think, up there earlier, that like 60 or 70%, I think, CBT-I you find is very effective for. Can you give a stereotype of that other 30, like what category-ish, or is that just completely random, of just random people, we can't figure out why it doesn't work?
First of all, don't undersell me. It's 70 to 80% get better.
Apologies.
Okay.
Apologies.
And the question was, might I be able to characterize the type of person for whom it doesn't succeed? Is that a good summary of the question? It's a great question. It's certainly one in research we'd like to answer the question. I don't know that we've answered it well enough. So all I can do is answer you off of 30 years of experience. I would say that what I say to people who come into my therapy is, after doing a full evaluation, I can usually put up a hand and say, look, you've got a little bit of sleep apnea, you've got a little bit of depression, you've got some chronic pain, you've got, we could name a number of different things. And then you also have the factors, disruptions in the factors that I'm looking for. Sleep drive, circadian rhythm issues, conditioned arousal, those sorts of things. So if I see those are there, I know they're at least targetable. Okay? And so I say, from an interview at the beginning, can we tell which one of these really is causing the problem? And the answer is no. And if some combination of them is causing the problem, what percentage does this one contribute? And what percentage does this one contribute? Okay? So in many cases, by the time somebody's come to see me, they're already treating these things, right? They're on medications for pain and depression and all those things, or they're getting treatment for those things, and they've gotten better, stabilized, but are still there. So they've come to me for sleep anyway. Let's look at the things that we treat. Let's pick this one off and see how far you get. And what the data tells me and what my experience tells me is I can get just about everybody at least 50 to 100% better. Okay? How many people don't get better? I would say the biggest factor, it takes some work, because what we're talking about is changing habits. How do I do things? You talk about, what should I do? Should I nap? Should I not nap? For some people, napping may be okay. For some people, not. And suppose you like napping, but it's not so great for you. How do you change that? Some people are going to do that, and some people are not going to do that. Make sense? So there are a list of things to do. And I'm asking people to change habits, and changing habits takes some compliance. Changing habits takes some getting adjustment to. Once you adjust to it, it feels fine. Nobody at the end of treatment says, boy, this feels uncomfortable. It feels fine. But in the beginning, changing any habit can be a little bit, difficult. So what I would say is, the biggest factor that causes people to fail is stopping. Okay? That's a big factor. But I always used to say to the interns that I trained, that if you give me somebody who did everything I asked them to do, I can count, up to this point, it used to be one hand. Now I'd say about 2 hands, the numbers of people who didn't benefit whatsoever. okay? And that's after thousands upon tens of thousands of cases. Now, if you say, who's less than 50% better? Again, if some of these other factors are very interfering, but we try to screen that out to begin with. So, you know, if somebody is, again, it's a matter of degree, and sometimes you don't know how much that matter of degree is going to matter. So women have hot flashes. Most of them will say, some nights yes, some nights not. When I have them, after a few years, it's gotten better, but they're still there. Okay, usually workable, usually no problem. But if somebody comes to me and says, every night, every awakening, every night is a hot flash, it takes me an hour to cool down, I have to ice my head and my back, that person might not get better with insomnia unless they get that under control. So it's a matter more of severity than what's the thing, you know? That's the best way that I can answer that. Thank you very much.